I want to just revisit a little bit now about the orthopedics of class 3. So where are we in this program? We started day 1 with etiology of class 3, okay? So regardless of whether you've got a pseudobite or whether you have a genuine 3A or 3B, you know, the same rules apply. Have a look at possible contributing myofunctional problems. Instanding lateral incisors, you know, obviously. Habits such as airway, tongue thrust, you know, all the things we look for, but specifically in class 3, enlarged lingual frenum is a big one, and enlarged tonsils. And you can check the tonsils really easily without a Ceph, just pressing the tongue down. Now, one thing I'm seeing in your photos, although yes, they've improved, you're only staying with the absolute basic photos, right? I need to, almost like a detective would in a crime scene, just photograph everything, yeah? So a lot of people were saying, I think that looks like a large tongue, you know, tongue tie. Well, why not take a photo with the tip of the tongue up here with a ruler, right? For a lot of people saying, I think he has large tonsils. Well, why not take a photo of that? People saying he has large adenoids. Why don't you, on your lateral Ceph, just do a circle around the thing? So it alerts me. And I ask my students when they upload cases to do that, you know, because I can't mind read, yeah? So the more information you give me, the quicker we can look at that. So just keep that in mind when we're doing our cases, if we can try and go outside the box as far as what information you're giving to me, right? So yesterday we led on from the epigenetic influences into the airway situations, right? We went then into the concept of what I do in early dentition, you know, deciduous dentition, and basically there's one of two choices. You can use Planner's technique. I wouldn't do it directly because I think little kids are a pain. You want to do it indirectly, and remember the whole concept is to do the incline like the plane landing, and to do the D&E as a unit. That's my advice, yeah? Alternatively, just eliminate that anterior crossbite, right? So open the vertical enough, you might just want to whack some resin on the lower deciduous teeth. I'll leave that to you, there's no right or wrong answer. What I did see a lot yesterday in the photos, and what I do see with all my students, is this tendency to open the vertical too much, right? The more you open the vertical, the harder it's going to be then to get your positive overbite at the end of the day. And secondly, that tongue is going to be encouraged to go into that hole, right? Your job, remember, posterior inclined plane effect, elevating the tongue, is to discourage the tongue from sitting downward and forward. How do we do that? Other than the build-ups, little cleats behind the lower incisors, and some form of myofunctional activity. Now, the YC3 has that acrylic that makes the tongue go up. The trainer has the little tongue tag, you know, but these are all as good as the kid wears the appliance, which is mainly at night. During the day, we want to have some good proprioceptive info, and so we want to get the little tip of the tongue on the palatine rugae, whichever way you want to do that. But right now, can you just keep in mind that the tip of the tongue on the palatine rugae during the day is more important than just that appliance at night. Does that kind of make sense? And if you only do one and not the other, see, I'm sick and tired of general practitioners just sort of saying, oh, this trainer's pretty good here. Here's one, good luck. You know, you're wasting your time. If the kid can't breathe through the nose, obviously they can't wear the trainer. And even if they do wear the trainer, it's not enough for tongue posture, right? We're talking about, if we can get that tongue retrained up on the palate. Anyway, we then moved on to 3As, okay? And 3As are the bread and butter of your early treatment class 3. Best time for 3A, let's review it. Based on vertebrae, by CVM2, but I still push it up to CVM3, particularly in boys, right? I think you get a CVM4 girl, forget it. I mean, not only is her face 90% finished, her maxilla is definitely done. Does that kind of make sense, right? But that still opens you to dental correction, yeah? So please understand, pseudobites, is there any upper age limit where you can treat a pseudobite? No. You have a 30-year-old with a pseudobite, get in there. Yeah? Now, how do we fix pseudobites? Basically, eliminate the initial point of contact. Secondly, light elastics. So these are the methods I went through yesterday. I went through the concept of using 2x4 just in the upper, low torque with either compressed coil a la Damon D-Gainer or with the stopped archway. Up to you. Once you've kicked those upper incisors over, if you're done, then that's great. But if you're not, you still need to get a bit better, then whack on some lower 2x4. Yeah? The upper, you can do stopped arch wire, you can do compressed coil spring, but you can't run elastics. Do you understand? Once you whack on the lower, it opens up Pandora's box in light class 3 and in those anterior trapezoidal behind the upper incisors. I'm just reviewing all the stuff you should be killing at this stage. Now, then comes, we did whatever we did for the kid. All the kids showed up at 9, and it's a first phase. Then you really got to get the maxilla expanded, and we're going to talk about that. The rate of expansion, remember, in my practice is always semi-rapid. Read the research by new published American Journal of Orthodontics, very good paper. Semi-rapid to me is not 2 turns a day like I used to and split the suture, right? I only do that if we've had surgery on the maxilla. It's not good for healing. Think back to course 1. If you split the suture and you let blood form and granulation tissue and immature bone, you're talking about a healing cascade that forms scar tissue. You're talking about high relapse, you're talking about forces where the teeth are going to push through the cortical plate and you are going to get gingival recession. So the slower the expansion, the better. But practically, if you do it too slow, your treatment's going on and on and on. So for children, I like to use semi-rapid expansion. For adults, slow expansion. So for adults, I'm doing the millimetre a month, okay? For kids, millimetre a fortnight. Not what I used to do, which is millimetre a day. Does that kind of make sense? But I cover that in course 1, just a touching thing. So the right expander is what? The expander that's going to splint the entire jaw. Does that make sense? So anything where the forces are going to be distributed to the bone, that's the right expander. And I'll go through some of those now. The second thing is the timing, which is the vertebrae CVN2, 7 to 9, based on the research. Second is when the face mask goes on, right? Now, you can't use a face mask unless the expander's already loosened the sutures. We understand each other? So how about like a month of the expander, whack on the face mask. And when you've maximized the expansion, you still would need protraction, right? So therefore, based on that research I gave you yesterday, you want to keep driving with the face mask and you want to start the expander going forward and back just to keep the sutures loose, right? What else? Force is orthopedic. So, I'm not going to, I'm not anal like, it has to be 525.5. No, anywhere between 500 and 600 grams of force, but not something like 150 grams because that's orthodontic. We need, the second thing is the duration. Now, you actually can't do 24 hours a day. So you don't want a kid to wear a face mask 24 hours a day because it's actually counterproductive. Read the chapter on profit on the whole concept of heavy versus light forces. Light forces, you want light and continuous. Yep, Damon. Heavy forces, orthopedic forces, you want heavy and intermittent. You actually want 12 hours, bottom line. So believe it or not, the research would indicate a kid wearing a face mask 24 hours a day is not going to be as effective as a kid wearing it 12. But I don't think we ever have the problem for a kid wearing it 24 hours, right? We have the problem the little bugger getting to 12, yeah? So duration, then direction. Direction is downward and forward. Everyone happy with that? Yeah? 30 degrees below the occlusal plane. Point of force application. Center of resistance of the maxilla, which is around about the cuspid region, yeah, 2/3 up the root. What about the center of resistance for anchorage in the lower gonial angle? Hence the Hickam bow we looked at yesterday, hence the Brazilian technique, hence the whole concept of using any bow in the mandible, such as tandem bow, the reciprocal 500 grams force, yeah, needs to be absorbed here, not in the condyle. That's why I said we can't use chin cups, yeah? Anyway, getting back to point of force application. direction, duration, timing. You know, these are all the things that you should be, regardless of what appliance, you should be going through your checklist. Now, if you get all that right, you're going to get success, right? But don't take my word for it. How are you going to measure your success? You're going to measure your success cephalometrically, yeah? Because if you're just mirroring overjet and you've gone from a negative overjet to a positive overjet, how do you know that wasn't just the upper incisors flaring forward? Yeah, right? So, I'm going to now revisit two appliances. One is the bonded Hyrax, which is my favourite, right? It's my favourite because it's predictable and you know, it opens the vertical and it gives you that acrylic coverage to slide the maxilla. Downside, it's a pain to take out. Yeah, deciduous teeth come out, high maintenance kid jumping up and down. So, you know, there's the thing. The only other appliance I use is called a McGill, right? And in a bit, McGill I use where I need a lot of sagittal drive. What do you notice about the bonded Hyrax? The bonded Hyrax gives you good transverse, yep? But if you don't use it with a 2x4, you're going to get a really square arch form. Who would agree with that? And when you do 2x4, light forces reverse torque, you get some sagittal, but not as much as you would if you had a true sagittal gear behind there, right? Now let's talk about premaxillary growth and development. Do you understand premaxilla stops growing before maxilla? So you've got to get in even earlier. But fine, if you have a young kid CVM2 who is maxillary deficient, yeah, underdeveloped maxilla, and is premaxillary deficient, meaning the upper incisors are real div 2, then I'd like you to use the equivalent of what you're used to in removables, which is a Schwartz sagittal, but I use the fixed version. The fixed version of a Schwartz sagittal, to me, is a McGill A, and I'm going to introduce that to you, right? Two appliances for my face mask, bonded Hyrax or McGill A. If you're doing McGill A, you can do it with occlusal coverage as well, no biggie on that, right? But the amount of occlusal coverage for your appliances needs to be just enough to clear the crossbite. I don't want to see like 6mm open bites like I saw yesterday in some cases because of the appliance. No problem when you fit it, if it's only contacting on the molars, which it will, grind the crap out of it, right? I don't care if you perforate there, it's only a temporary appliance, not like, you know, I mean, you guys are used to perforating as you fit crowns and things like that. It's a very similar deal. But unlike your crown and bridge work, you know, this is only a temporary deal. You might only have the thing in there for 6 months, right, Ian? We can't slow the growth of the mandible, but we certainly can increase the maxilla to its maximum genetic potential. So we're going to do that using reversible headgear we talked about yesterday, right? In reversible headgears, don't care which one you use. Remember, this whole 3 years is not about what you use, it's how you do it, right? I personally love tandem bow, but huge, big expense. Second best option, without the chin cup I'm talking about, is Grumman's. Poor third option, without the chin cup, is going to be one of those Leone, you know, zygomatic face masks, yeah? As far as chin cups, love the petite, right? It's good price, kids love wearing it. Only thing to be careful of, when you adjust it, you know, I want to see the periscope here, it's up there, yeah? The other second best after that is going to be your standard Delaire. It's the cheapest one on the market. You know, pad here. No problems in low angles, no history of TMD. Big problem in high angles because the mandible rotator, contraindicated in TMD because force is definitely being upward and backward, all right? Now, we touched on VCC. You don't really need to know a lot of that at this stage unless I see a case of yours that needs some vertical finishing at the front of the wedge. When we do course 7, you're going to be all over VCC. Because the young kids who are high angle, you're going to control them orthopedically by intruding their molars, and as you do that to close the wedge down, you're going to help auto-rotate the mandible. That's what a VCC is good for, just to give you an idea on face masks. Okay, this study, and we mentioned it a little bit yesterday, done in Manipal, India. All right, now, this research in Manipal, they basically looked at a 3D analysis using computer photography, and they looked at what would happen if you only expanded or you expanded and used a face mask. So let's have a look at this. So remember, this is not actual patient stuff, but it's a very good research project. So here's your 3D model of a midface deficient maxilla. And what they're doing here, they're looking at the pattern of forces, what Dr. Grumman's referred to yesterday as his circumorbital forces, which Hans and Enlow chapter, growth of the nasomaxillary complex. The nose is intimately related with the maxilla. That's why you've got to get a good ear, nose and throat doctor to work with, trust me, right? Half these maxillary deficiencies related to airway, I'm convinced of that. 85% of the maxilla is made up of nasal airway, or if you want to look at the other way around, the floor of the nose is intimately related to the palate. So you've got to, ear, nose and throat guys need you desperately. We need them. I hope all of you have got George Meredith's ebook and started getting that out to, your local guys. And as I said, as much feedback as I can get and people that I can get to know in this country that are good, that you're looking for, just bottom line, you're looking for specialists in your country that travel. Does that make sense? You don't want the sort of specialist who on the CV goes to the annual British Ear, Nose and Throat Association meeting. That's it for him. You want someone who's in the States a lot. You want someone who is part of their memberships, is American, part of the American Association of Otolaryngology, that sort of thing. Look for the American trained people or those exposed to it. Trust me. This is at the level of the nasomaxillary suture, but this is only with a face mask, right? So stress with a maxillary protraction. Now they go a little bit deeper. Here is the most important suture when it comes to bringing the maxilla forward, right? Zygomatic temporal suture. Yeah, that's what really is going to free up that maxilla to go downward and forward. And here is the next important suture, sphenozygomatic suture, right? But all of these patterns are with maxillary protraction only. Now they do the exact same, but this time with maxillary protraction and expansion. And look at the absolute changes. I mean, you just can't, it's chalk and cheese. At the level of the zygomaticotemporal suture, at the level of the nasomaxillary suture, and at the level of the sphenozygomatic suture. So in your notes, right, if these are foreign terms to you, in the chapter on growth of the nasomaxillary complex, you need to understand about these sutures. Now these sutures are classical Melvin-Moss, form and function. Yeah? They don't have any inherent growth potential, but they do grow in response to forces. Now in theory, if you have a young 2A, you should put compressive forces on these sutures. Do you understand? So I do use the old combination headgear in 2As, orthopedically. But more and more, your patients are maxillary insufficient. Do you understand? So you need to stretch the sutures. Does that make sense? Right? Again, you need to be driving the engine. So, you get some chiropractor, cranial osteopath, Johnny come lately, and says, oh yeah, I can do this, I can do that. Quiz them. Say, which suture are you going to work on to help my maxilla come forward? And if they go, the anal one, that's not what you need, right? So, but if you don't know, you'll be led up the garden path by this guy who'll feel craven rhythm, You want someone who knows their shit, right? SOT. Look for someone and you can't get SOT training here, just quietly, right? So sacro-occipital technique, chiropractor. I think you all call them chiropractors here, don't you? We call them cranio-osteopaths. America's called them physical therapists. They're all the same little deal, but you quiz them, right? You don't just say, oh, look, I've got this maxillary insufficient patient. Can you help me? Of course I can. We have those all day long. How are you going to help me? Yeah? If you have a patient you want to encourage class 2 correction, mandible going down and forward, they need to work on the temporal bone, yes? If you need someone who has maxillary expansion, they need to know which suture. If you have someone who needs pre-maxillary development, does that kind of make sense, right? So again, I firmly work with, in my country we call them, cranial osteopaths, and they're really good. But again, there's good ones and there's bad ones, just like there's good orthodontists and bad orthodontists. So please, I said this in course 1, I know a lot of you haven't done it, go back and really read just the 1 chapter on Hans and Low, growth of the nasomaxillary complex, understand the sutures, right? You all know about the sutures to develop the jaw. I mean, that's not rocket science. I'm talking about the sutures that allow the maxilla to grow forward. You need to stimulate those sutures, do you understand? And if someone is wearing a face mask and wearing it well, and you're getting someone to manipulate the sutures, let me tell you, it's like doing a surgically assisted expansion of the maxilla. Do you get that? Right? So all you need is one good guy. All you need to explain to the parent, listen, your upper jaw's back, and it's easy to do with your Jefferson tracing. I want to get it downward and forward, but it's kind of semi-super glued to the skull. The way we can loosen up those sutures, I mean, the more you know, the more you articulate you'll be to your parent. So all my face mask kids, particularly those that are CVM3 and I'm pushing the limit, you understand? Definitely seeing the cranial osteopath. The young kids, no problem. Young kids, I mean, it's perfect age, good stability. So let's look at this kid. All right, he is the ideal candidate. He is maxillary insufficient. He is a 3A. He's CVM2, okay? He has no room for his lateral, and his laterals are in crossbite, so he is having the need for upper arch development, and he's got a neutral mandibular plane. Everyone can kind of see there that those cuspids are in a good zone to erupt, but at the end of the day, it's this that's too far back. Now, he's got no airway problems, okay? Our goal is to get that and bring it forward. So how do we do that? Well, you need to clear the crossbite. How do you clear the crossbite? With the bonded hyrax. How much? Just enough to clear the crossbite. Yep. So everyone happy with this? Fit the bonded hyrax to start with. Yeah. Start the semi-rapid activation. Super screw. 1 turn a day. 1 swing a day. When they're happy that it's working and it's all loosening up, and you can see that because with the super screw you can measure the gauge, yeah? That's the time to whack on his face mask. Now he's a neutral angle, so you can go for the cheapest face mask. If it was a high angle, then you're talking going without the chink up. Everyone happy? So how about, just trying to get you to make it practical, how about bonded hyrax, petite face masks? Happy? Bonded hyrax for a month, right? Face mask added to that a month later. Face mask wear 12 hours a day. All right, blah, 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 blah. Then, the next visit, have a look at how things are moving. If you're well clear off the crossbite and the lateral has come through, good time to start low torque, upper 2x4. How's that sounding? Right? Now, how do you do upper 2x4 with the bonded hyrax? You would have already planned, based on my design, to have your molar tube mesial of the acrylic. Yes or no? From yesterday. So dead easy. 4 brackets, yep, and the light 014 wire going from the molar tube to molar tube going through those brackets. Everyone, you understand? Good practitioners, those who are doing the more the Damon courses, would automatically go for a higher negative torque on that than this. Yes, because of the root. And we know this is going to end up there as well. Right? We're sort of understanding each other, right? Now, you don't need to put anything in the lower arch, correct? And you don't want to because you don't want to marry that lower jaw. Remember we talked about yesterday? When would you consider putting something in the lower jaw? David? What's the indications where you would go a little bit outside the box and put something in the mandible?
It's a pseudo, and you've got growth.
Okay, if it was a pseudo, then you'd probably consider lower brackets with elastics. Good. I'm talking about orthopedics. When would you put in one of those lingual holding arches? Yes. If you have a high angle, you're using a tandem bow. Secondly, if you have a 3C. Remember that? If you have a 3C, what do we use that for? Even the 3C deep bite, David. You understand? 3C deep bite, you don't need the tandem bow, but you would like to have those class 3, right, elastics driving on that. So write that in your notes. When do I do anything in the lower? You saw that yesterday. You know my appliance in the lower, bands on the 6s, yeah? Lingual arch. Can anyone tell me why I don't use a labial bow? Right, because I'm worried about dehiscence, yeah? But I just want the little hooks for the class 3 elastics and the rest. You go look at your notes. But I'm just trying to help you out when I do that. I don't do that for all my kids. 80% of my patients are 3As, okay? And if they're 3As with deep bites, not interested in touching the lower jaw. If they're 3As with open bites and I'm using tandem bow, I'm married to that anchor unit in the lower jaw. But if I use a Brumman's face mask, I can get away not touching the lower jaw. Do you understand? When do I have to touch the lower jaw? 3C. All right? And if you are using the lower jaw for anchorage. Bottom line. And good answer, I said lower jaw, but I understand where you're coming from. I also would entertain doing lower brackets to help my pseudo bite. Okay? When would you, how would you know what prescription to use? Well, the angle of the lowers, right? 3Bs, as you get towards the end of their growth, they're like that, aren't they? So positive torque. You understand? The 3Cs, you'll find those uppers aren't that bad, and you don't want them to go here. Do you understand? So what you don't want to do, and this is where the average mind thinks, oh, it's class 3, I want to throw the upper incisors forward, lower incisors back. I'll use high torque upper, low torque lower. Absolutely wrong. Do you understand? Read the Bill Thomas article on variable torque. Memorize that slide. You know, we went through that in the Damon program.
In 2x4, otherwise the torque makes
Yeah, exactly, yeah, exactly. Or you might just use it for the elastics, right? I'll come to that in straight wire, right? So hold that thought. Oh yes, correct, yeah. Many times, if I'm doing it just for tipping the teeth, beg bracket, you understand? Beg bracket round wire. Nice and cheap, easy, and I'm just tipping the teeth. I'll come to that when we do straight wire this afternoon. Okay, so this dude, he wore his face mask really well. His 4 upper brackets were put very gingival. He's had a very good result, and the parents are so pleased, as you can imagine, right? Because little Johnny comes in with that, and he's non-postural. Do you understand? There's a family history of class 3 jaws. She's been told that 18 surgery. If I did the Cephalon as a 3B, I would agree, yes or no? If it's a 3C or 3, I'm getting in there, yep. It's a 3A, it's a perfect job for you. So, he wasn't the world's best face mask wearer I made either, but you still get a nice result. You know, can you imagine the grandparents who are used to seeing him once a year? They then see him post-ortho, you know, next thing they want my business card to give the entire bloody family. This is a real practice builder. Now, we're at this stage, okay? We've got the little Hilger's wire temporarily, upper and lower. In this kid, he kept breaking his upper. What else will we use as a retainer here? He was a 3A. We're going to cover retention tomorrow, but just let you think out the box. You can't just give him a little wire upper and lower and say you're done. What are you retaining? Yeah, you're retaining your maxillary protraction, yes? So how about a modified Frankel 3 home at night time? Right, and we're going to cover the designer for Frankel, how to activate it. But just trying to get you to logically think this case through. Right now, you guys should really be getting the treatment plan spot on. Right? There's his bonded hyrax with his face mask hooks. You can see that maxilla is driven forward very nicely. And, as soon as those laterals were there with the right torque, how would I look at cases of yours and say, look, that's not successful, when I see upper incisors left like that? When I see edge-to-edge bites, do you see? Right? When I see no room for the cuspid. If you show me one of your phase 1 cases and I look at it and I realise that there's still no room for the cuspid, I'm going to say, well, what have you done? You may have brought the maxilla forward, but at the end of the day, you have to go back with another go of phase 1 orthopedics for the cuspid. So what we want to look for is a positive overbite. We want to look for a good face. We want to look for a nice smile line. We want to look for room for the cuspid, right? And you can, that's a C. You can drive a truck through there. The guy's got plenty of space. Yet he started with bugger all room for the lateral. I also look at the crossbite, yep. And I guess, Frank, your case that had that amount of relapse, I mean, what retainer when the bonded hyrax came out? These are the things, because remember, no matter what we do, there's going to be relapse. The quicker we do it, the more chance of relapse. But a Frankel, if the kid wore it, is going to maintain the upper arch width. And upper hinges won't. If in doubt, think back to course 3 mixed dentition. What fixed retainer could you use to maintain arch width? Think about that. So there's nothing wrong, if you're worried about the kid not wearing his Frankel, lingual arch from 6 to 6. Remember we showed you that? With the hinges. Hinges for the teeth, lingual arch for the width. Does that make sense? Now, if you're clever, you'll have your lingual arch with an omega loop. So then, if you want to drive, it's a fixed sagittal. Do you understand? Right, so I'm giving you all the things, but you've got to just sit down and think, well, hang on, I've done this, what am I retaining? So to me, this guy's going to be a Frankel case. How long will I ask him to wear the Frankel? I know 1 hour after school and all night, but how long? Like, to what stage would I reconsider doing something in the lower, strapping him up? Anyone? Yeah, boy, CVM 6, when we are 100% sure there's no mandibular growth, right? Now, sometimes I'll admit to you, books are empty, we want to start a bit earlier. I will get in at CVM 5, but I will never get in before CVM 4 because that's when the mandibular growth is occurring. 85% of mandibular growth occurs between CVM 3 and 4. So that's not the time to start lower mechanics. I will do full fixed, younger, if the kid was skeletal 1 and had a pseudo bite. Does that kind of make sense? Right? Yep. When will I really be careful? Not so much on my 3As, but my 3Bs. My 3Bs have the propensity of a lot later class 3 growth, particularly the boys. So, there's no absolute rules, but there's certain things I do and I don't do. Now, the lower jaw had 4 brackets. For what reason? Just so I could get him to run some elastics. And I don't really have to retain a lot. I mean, I didn't really do a lot. But a lingual wire is a good way to just keep things in check. So, typical case of class 3 maxillary deficiency orthopedics, going to a Frankel, holding on that Frankel until he's rocking, rolling for his vertebrae. Okay? Once you've done that, then you're getting good stability. Problems I see, missing the boat at the right time for the face mask, or getting in too early for fixed. It's all about timing now, all about timing. You can never bring the maxilla too far forward. We talked about that yesterday. You saw that case yesterday that had a massive overjet, look class 2, but look how it finished. A lot of that's dental. Yeah, it really is impossible to over-protract a maxilla, right? So when people ask me, when do I stop the face mask? If you overcook the face mask, it's not the end of the world. It's the undercooking that I'm concerned about. Class 3 elastics, we talked about them and the use of the lingual arch or the holding arch, but we never use them with the history of TMD for the same reason, forces going upward and backward. We also need to understand, and Skip talks about this a lot, the Klein effect. The Klein effect is tilting of the maxilla, right? It occurs if your orthopedic force is placed too distally. I get some people get lazy, they don't want to make an orthopedic appliance, and so they'll go 2x4 upper and they'll start wearing their face masks to the hooks on the upper 6. That's a no-no, right? You need to put your forces through the jaw at the center of resistance. What else is a no-no? Being in a rectangular wire in the upper, 2x4, whacking a big hook on the wire and wearing the face mask to that hook. You saw that yesterday. You're going to get purely dental alveolar. You'll get the upper incisors flaring forward, not going to help you. All right? So we talked about forces of elastics. So here's your checklist. In Damon, we have a checklist. What is that? What talk, right? What variable prescription? Elastics early, yes or no? Disarticulation, if so, where? Engage all the teeth from day one, all the stuff I've covered. Class 3 checklist. Etiology. We have a dental component of class 3, a skeletal, a functional, a combination. Is it mainly a 3A or a 3B? What's the vertical? Because if the vertical's open, whole mechanics is different. Lastly, growth potential, which is based on the vertebrae. Now, hereditary, I asked the questions, but that's not always the gate solution, because if the parent was a misdiagnosed epigenetic problem, then of course you'd say, oh, well, it's class 3. Now, is there a class 3 generic inheritance? Absolutely. What's the most common? Class 3B long. So be careful when you have a 3B long, look at the parents or grandparents. My practice, when I have a 3B long, I make the parents, mum and dad, come in for photos. Yeah? Little marketing tip for you. Anytime you have a child, you're starting treatment, right? For any, I'm not about class 3 for anything. If you really want to boost your practice, say to the parent, okay, I'm taking records. I want to look at the genetics of your son's jaw and bite. Can you and Mrs. Jones please come in for records? There's no charge. Now, you understand I've only got 1 foot in your practice. And when you're doing the case presentation for the kid, you throw up their records. When you see, and I do all my presentations on a screen this big, with a digital projector in a little room. Yeah? When mum, in particular, sees the tissue, she goes, you know what? I've been thinking this for years, and seeing you've got the records anyway, can I start? Hello, ka-ching. Yeah? And now that you've got all these Damien skills, you're going to kill that as well. So keep that in mind. Best marketing tip I can share with you, the need for genetic records. How's that sound? And parents, they do anything for their kids. Even dad, who's a busy banker, he said, look, I really need to look at your jaw, Mr. Jones, because it's going to influence what I do for your son. Shit, all right. Can you see me Sunday 5 p.m? Absolutely not. Right? But my young associates take the records, so sure, schedule them whatever you want to, and so good. Mrs. Jones, I'm glad you and Mr. Jones are here. It is very important for your son. Do the whole spiel. Many times when I'm running late and I don't have time to present the parents' records, the parents say, oh, how about our records? Can we have a look? Seriously. Yeah? And when my associates are taking photos, of course they just turn the camera around the other way and they say, Mr. Jones, have you seen the recession you've got on that tooth? Bring that up to Dr. Mahoney when you see him. Do you understand? You're building in a need. Yeah? It's much better than a mailbox drops, are you interested in Damon? So, class 3 maxillary insufficiency. Look at the face. What else could you look at? Photos, John Mew, sclera of the eye, Mew indicator. All of that doesn't need x-rays. Do you understand? But you'll get a sixth sense after a while. You look at that girl and you do the as if, yeah? And unfortunately, you can't do an as if of the maxilla coming forward, yeah? But you certainly can do a cephalometric tracing, soft tissue superimposition. You sort of show the parent. The other thing, remember, someone's going to remind me to email you the guy, Bruno, his name is, he's in orthodonts in Brazil. He has that service where you can send him a photo like that and he can mock it up like that to show the parent. And it costs like, $10. It's a pretty good deal. Obviously, I don't print it out and give it to the parent because you don't want that, oh, look, you promised this and blah, blah, blah. Just like in Invisalign, I never print out the, prediction and things like that, but it's very good at the console. Anyway, this is not a morph, this is actually the treatment plan. So we're talking here, maxillary insufficient high angle, right? Now, Shane, how would you think differently on this case compared to the last kid who was a neutral or low angle? They're both 3As. This is a 3A long.
They wouldn't be using a chin.
Good, perfect. Yeah, so you'd still have the occlusal coverage because that's the deal to slide the maxilla. Yeah, but two things: you would certainly avoid the chin cup. Right. Secondly, if there's a stage where you take the bonded hyrax out, yeah, but you're still leaving the upper 2x4 on. Do you understand? You would make sure on the day the hyrax comes out, you have molar tubes on the 6 very occlusal. Do you understand? Yeah? So these are the sort of things that will go through my mind. As far as the Frankel, there is no modification on its design for the high versus the low angle, unlike a binator where you have a binator open and binator closed, right? Frankel 3 modified, you don't have that deal. Yep. Frankel has a thing called a Frankel 4, which he used for high angle open bites, but it's different for when you're doing a mid-face deficient case to retain it. Now, proof in the pudding. How can you check that you had success in this case? And again, Dino, looking at that tracing, where is the dotted lines are the end of treatment. Knowing that this was a high angle class 3A long, that Ceph is telling me something that went good, something went bad. Can you help me? What went good?
The good thing is that the maxillary...
Yeah, because if PTM is your stable landmark, you have a linear increase of maxilla, not a change in the cant. Do you understand? Right, so if you use the Klein effect and you got your maxilla and tilted it back or tilted it up, it's not really full thing. Good. Now what's bad about that though?
It became even longer.
Exactly. Why? Because the wrong face mask was used. Does that make sense? Right? Can you see the mandible has extruded? In a really bad case, it would rotate downward and backward. Does that kind of make sense? Right? So I want you just to be critical of what we're doing at the end of treatment. So expansion, it certainly has an extrusive effect. That's what we're getting at. You do get the mandible rotating open as a byproduct, unwanted byproduct in high angle cases of mobilizing sutures. That's the point we're getting at. Secondly, if you're using face masks, you need to put the force through the whole arch to get the orthopedics. And once the sutures are starting to mobilize, you want to bung on your face mask and then finish up with 2x4 and or class 3 elastics. There's the protocol. So, severe cases that normally would need surgery, if you wait until the maxilla stop growing, they will need surgery. You're just fulfilling your own prophecy. But if you get in during growth, you can actually get some amazing changes of the maxilla. It is possible. Look at it the other way around. What happens if you don't treat early? Okay? I was trained in class 3, do not touch till growth is complete. Totally wrong for 80% of cases. So the whole, second opinion, this little girl comes to me, cute as a button. You can just tell she's flat in the face, can't you? Right? I look and I see she's edge to edge, but she's very early she's CVM1, okay? There's no functional shift. So I'm throwing some, real life scenarios. Okay, I'm throwing something at you. We talked yesterday about getting in early on the little kids, even in deciduous dentition, if they had a pseudobite, correct? What happens if they don't have a pseudobite, but they're too young for face mask therapy? Who would do something, who would not? Yeah? And if you do something, what would you do? Well, you could still work on tongue posture, couldn't you? Yeah? So, your goal is to get that tongue up on the palate, and that would start helping things. So do I use... Now remember, Frankel would start Frankel 3s at this age. Yeah? So the equivalent of us doing that would be some resin on the lowers, yeah? And some cleats behind the lower incisors, and some myofunctional therapy. Nothing wrong with that. Bottom line is, though, I'm probably going to hold off on her. Until what stage? If she's a 3A, probably 7 to 8, and I would look at it, if you don't want to take x-rays and do the vertebrae, what would I look at? 4 incisors. Right? So that's the stage where I'm going to kill it. Now, yes, it looks more crowded, and the parents are getting more worried, but we wouldn't get any benefit of just doing up a 2x4, would we? Now, at this stage, we haven't missed the boat. It's a 3A, right? So what would you do here? Hyrax, face mask, obviously up a 2x4, and get over the bite. So it's all about timing. Class 3 growth, and I always say this to parents, is predictably unpredictable. Yeah? So we can try our best, Mrs. Jones, but there is no guarantee. However, if you don't do anything, then the chance of surgery, the percentage chance, it increases. So I just draw a graph when I talk to parents. I say, okay, this is where your kid is. Yeah? We don't do anything, 100% he's heading, and I write surgery here. If I can intercede round about now during growth, we get the chance of surgery coming here, but I say, but there's zero. You 100% guarantee you're in the wrong practice. I'm just honest with the parents. Right? And I've never had a parent say, look, unless you can give me 100% guarantee I can't avoid surgery, I'm not going to do anything at this age. No way. They are talking me into treatment for these patients, particularly if the referring dentist is someone who's, trained in orthodontics and understands class 3. I have a lot of GPs who I've taught over the years that refer all their tough cases to me. And they do the easy ones, and that's fine. But the good thing is when they send a tough case, they don't just say, I'll pick any orthodontist. They say, listen, Mrs. Jones, your son has a really severe problem. He has a class 3 open bite. There's only one guy in Sydney who can tackle this well. I trained under him, but be warned, this is a tough case. So parents coming in already saying, look, you're the guru, we know our kid needs help. As opposed to the general dentist has no idea about class 1, 2 or 3, no idea about orthodontics, who says, well, I think you need orthodontics because there's a bit of crowding here. Yeah? In the patient's mind, they're saying, we're not too concerned by the crowding. Right? And I come in and start the whole, your kid's got class 3 jaw, and then they're records for second opinion because they don't really understand. All right, so we do aim to overcorrect, and our primary orthopedics is directed at maxillary correction because at the end of the day, we can't stop mandibular growth. Now, let's talk about removables, seeing Ian brought up the subject. And this is from Skip's notes, and this is a very good appliance. And Skip, for a beginner, teaches it well because you get someone who doesn't do a Skip course, who gets a lab to make this, they don't know how to adjust it. Who would agree with that? Right? I've seen guys who start activating the sagittal gear and they don't release the labial bow. Where's that going in a hurry? Right? So, Ian, nothing wrong in that last case starting with this, but not with a big fee. Right?
But also not the downside being it wouldn't help the tongue posture.
Not at all. Exactly. That's why I've gone away from that. But I'm just saying, my view is not to say Mahoney's way or no way. My view is, look, there's many ways to skin a cat, as long as you do something positive. But I'm also showing you what I used to do, which, it doesn't work well. Okay, so this is called a short sagittal. When you have one of these, you have the option of having sagittal gears and a midline gear. And I would prefer you to have the 3 gears. Whereas if you have a 1 3-way screw, you're kind of limited into when you need to drive forward, when you need to go back. Remember, anchorage of your posterior teeth will help your sagittal drive. So you can add different things. So there's no, one appliance. So this is a Schwartz sagittal, 3 gears, or the 1 3-way screw with occlusal coverage. Why? Clear the crossbite. With a very Frankel effect here, which is to stop the restraining fruit. Now they all have that, don't they? The Chris Farrell cage IC3 keeps that. The younger, help me? Younger, you got to say it slowly though, my dear. Huh? Yanagi-sawa. That's nicer. Yeah. Dr. Yanagi-sawa has the same effect, right? So nothing wrong with doing that. Yeah? You might as well get the maximum you can for the orthopedics. But between the 2 removables, I like the one that has the short sagittal combination. So to me, if you're going to use removable, short sagittal with occlusal coverage, and believe it or not, I don't use a labial bow, right? What I find is the labial bow is a headache to adjust. And I don't really need it, just like if you look at Frankel 3s versus Frankel 2s, there's nothing on those upper anterior teeth. If you get good retention here with some double class, if you put some composite resin on your deciduous teeth to give you undercut, the only thing here is seeing you driving forward, you might want to entertain having a little C-class either side of the lateral, if you're worried about retention. But the labial bow really, to me, is not a good deal in an upper 3D. But, now realistically, what do I use in practice? I use fixed, right? So this is the fixed short sagittal. This is called a McGill A for advance. So let's have a look at it. It has the anchorage of the posterior teeth, and it has an Allen key here, where you come in from the front, you turn a key, and as you turn a key, it's driving the premaxilla forward. As you're doing that, you've got a screw, as you would for any expansion. So you can expand, you can do both, you can do one or the other. So that, in tongue-wise, is pretty good. You understand? Right? This is developed by the guy who really has written the most in expansion, this is a guy called Dr. Haas, right? And the Haas appliance, he believes if you put acrylic, you get better movement of the palatal vault. That's his. Research has indicated that actually is not true. So to me, I don't have acrylic in the palate. A, for the tongue. B, hygiene's a nightmare. All right, fixed acrylic. Even yesterday in my lecture on distal driving, you put acrylic in the palatal vault for anchorage, but let me tell you, it drives it into the soft tissue, yes or no? And food gets caught there, and there's a cesspit. TADS, much better, much more hygienic for the same purpose. So I used to use the sort of, I guess, semi-fixed expanders, if you want to call it that. I went from my removable stage of compliance headaches to one that you could at least put bands on. But the problem is, now I just don't want all this acrylic. You don't need it. So we're going to the Hyraxes. And it can be banded or bonded. If it's face mask, it's definitely bonded. And I like the framework to be such that it's giving me the retention. This comes from McNamar's article we discussed yesterday from JCO that described the use of bonded Hyrax and petite face masks. You're seeing here a mixed dentition case, and ideally you want the acrylic to go from C to 6. You want the hook to be near the centre of resistance. The only thing is you are going to prepare for 2x4, so McNamara doesn't do 2x4. He likes a bit like Dr. Grumman's. It's like the orthopaedic phase and then get out and then reassess. To me, I'm always doing 2x4. That is my sagittal movement and my reverse torque. So what's the difference in my design? Here, I always ask for the tubes to go in. Understand? This is the full dentition version of the bonded Hyrax. Again, should go from your bicuspid down to your second molar. Now, if your second molar is not fully erupted, please put a rest, etc. on there, because you don't want, after expansion, to have a whopping big open bite because the 7 over erupted. You know the rule in that regard. I've gone to super screw versus jack screw just because I get better orthopedic. But the framework for your bonded Hyraxes is important. If you just have acrylic and some technician has just put the metal arms of the screw into the acrylic, you're going to get failure. You're going to get it coming loose. When the face mask comes on, the face mask pads will come out. So the face mask pad is part of the framework, right? Think about like when they're building highways, if they just pour concrete and they don't have any scaffolding or metal framework, the strength will do the exact same with this thing. So be critical of your appliances. Yeah? You need to get it spot on. Now, Dino was talking about the spider gear. And to me, when you have a maxillary insufficient class 3A, most of the insufficiency is in the bicuspid canine region. Who agree with that? So what I'm saying in another way, when you do Short's Corkhouse, most of your narrowness is in the shape of a triangle where the molar distance is not too bad, right? Unfortunately, a Hyrax doesn't give you differential expansion, does it? That's only one drawback of my super screw. Yeah. So if you want to compare one advantage of a removable to a super screw, if you have a Shorts with 2 screws, one in the front of the pallet, one at the back, you can do differential expansion. The fixed equivalent of that is this by Leone. It's called a spider gear. So what happens with this, as you turn it here, it actually opens like a fan. And as a result, you get the expansion where